Severe head injury.
No.
When they indicated. No,
Only indicate.
Just a random question.
My,
When a person requires anti-epileptic for any indication, how long you continue after injury, right?
yes.
Okay.
None of you give.
You see, I gave up to 1 year. We did a study long back, about 20 years back. We saw that 80% post-operative epilepsy. Satish Jain and me did a study between 99 and I think 98, 99, and we saw that 20% of 80% occurrence has 1 year, and next can occur next 10 years. So we thought rational would be wherever you think indicated anti-epileptic, give for 1 year.
Yeah, and you give. So only 2 people gave, and rest you also give. Slowly, one by one hand come, but but if I think politically, I am sure I'll win because everybody will give, because nobody wants to face a challenge.
But you didn't ask other. I mean, how many give for lesser periods? You just said.
Obviously, it's the other.
Less than 1 year.
You should ask for 6 months, 3 months, 1 month.
Yeah, 1 week. Anybody gives for 1 week?
Everybody will give.
Yeah, more than 1 week.
Around 2 weeks. That is what I prefer.
Yeah, 1 month. So, so nobody means more than 50% don't follow the guidelines of giving for 1 week. So politically, like, we don't want to face a problem, either medical legal problem, or face a challenge from the patient if he comes back with a seizure for a second admission. But theoretically, I'm not correct. I'll skip this. Now, we know that the risk of epilepsy is very high, especially in high risk. The early in depressed skull fractures or intracerebral hematomas, subdural hematomas, we have a very high risk. Similarly, if you have a penetrating injury or cortical contusion, the risk is very high. So, whether is there a role in group 1 in early and group 2 is late? There is no controversy that in early post-traumatic one has to give, but then there is a controversy that whether you should give in post-traumatic epilepsy in late post-traumatic or not. In group 1, usually it is given to prevent or avoid complications in severe head injury. Whereas in group 2, the aim is whether we can reduce the development of post-traumatic epilepsy, whether we can avoid from seizures to epilepsy. Now, this mechanism has already been explained, where the target one is whenever there is a primary injury that can cause seizure, and seizure can again is a vicious cycle of damaging. So we give anticonvulsants here. There's no confusion in this. But here, when there's a repair mechanism comes where the seizures becomes epileptic, do we have any drug which can prevent the seizure and it can prevent neurogenesis or the mossy fiber sprouting, so that we can prevent the post-traumatic seizure becoming epileptic. And all of us know that 15% also can become intractable, and post-traumatic epilepsy do not remit as good as a general epilepsy. So ideally, it's better to give. Now, if you look at the papers in the past 3 decades, the opinions have changed. When you go to 1970s to 80, they told that the anti-epileptics prevented the development of post-traumatic seizures. There are papers which already Dr. Manjari had explained that in spite of giving anticonvulsant, there was no difference. Whether you give or not, the incidence of seizure was similar. Now, this was a landmark paper when they said that when they continued to give for 2 years, it only reduced the seizure as compared to placebo from 14% to 3.6% in the first week. Whereas in first week, in the 1 year, there was no difference. Rather, it was higher. Similarly, at the end of 2 years, again, it was higher.
No, statistically significant. This percentage doesn't matter in the big series.
Yes.
It is statistically significant.
It is.
It may look 2% versus 5%, but significant. It may look 3% versus 14%, not significant.
Yes.
So what is p-value? Percentage is no meaning.
And when they did EEG for all the severe injury, when they did EEG for this, at least seizures was EEG was epileptic fits was seen in 1 in 5 patients in the first week. So this again proves that anticonvulsants are helpful, will be helpful. Now there are randomized clinical trial, many trial, and Cochrane review also. Now it was clear that they were seizure free, but it did not reduce the neurological disability or death. So the practice parameter is that prophylactic anticonvulsant is required in the first week in severe injury, and from earlier it was phenytoin, nowadays levetiracetam is a better choice. Now, whether it is helpful in late post-traumatic epilepsy. Again, we know that whenever there is a penetrating injury, the incidence of seizure is 53%. And when you have an early seizure, again it is 47%. Intercerebral hematoma incidence 40%. When you have such high incidence of seizure, are we right in not giving anticonvulsants? So, AED is required logically, but the right drug is not available as we are not clear on the pathogenesis or the right drug which can prevent this. One of the pathogenesis is iron-induced lipid peroxidation of membrane, and which can cause seizure. Now, we also discussed about the mossy fiber regeneration and the death of the granules and from the CA cells also. Now, there are no drugs to prevent this reorganization activity which produces seizures. Now, the controversy is whether if a patient comes with a single seizure to treat or not. A non-traumatic or a traumatic should be treated separately. Even if a patient has a seizure 10 years ago, if he comes with a single seizure, they have to be treated, as 86% of them can have a second seizure. So unlike a patient who doesn't have a trauma, a patient where you think of only when there is a second seizure you go and treat with anticonvulsant, in post-traumatic one has to treat with anticonvulsant even if he comes after 10 years of seizures. The lifetime total number of seizures in patient with post-traumatic is not associated with the age or severity of the injury. And as I already told, that 30% of them, 38% can have more than 30 seizures in 40% of patients. And 13% can have intractability. So once you started, when do you stop anti-epileptic in late post-traumatic epilepsy? The remission rate is poor, 25 to 40%. But and especially if the latency period is more than 4 years, they do not remit also. But then if the patient is seizure free for 2 years, then one can stop the anti-epileptic drug. But if it doesn't stop, if it continues to have seizure, then they should be evaluated for intractable epilepsy. So in conclusion, it's helpful, definitely helpful in early post-traumatic epilepsy. And it's also helpful, it should be helpful in late post-traumatic epilepsy, as the incidence of seizure is very high, but then we do not have the right anti-epileptic drug. I know in future, if you come out with the right drug, all of us will start that drug to prevent epilepsy. Thank you for your attention.
These are all these doesn't include non-convulsive seizure, right? These are classical epilepsy, right? When you talk about this person, they don't include non-convulsive seizure. Do they include?
Do include, sir.
So, to continue with the debate, we have Dr. Michael Bell, who will speak against giving prophylactic anti-epileptic drug therapy. And then after that, if Dr. Manas wishes, he can speak maybe a few words on counter-rebuttal.
Let me say as a disclaimer, I didn't get to pick which side I was on these arguments. And for an ICU doctor, long-term means about 2 days and not 6 months. So when it comes to long-term things, that's my perspective of things to begin with. But I'll do my best to make the argument tenable. Thank you very much. So I can be quicker than 14 minutes, and I'll abide by the chair's 8-minute discussion. My disclosures again, as an ICU doctor, seizures for me are ICU-related things which I treat all the time, but I will try to do my best to make this argument. So I think there are some facts that were outlined mostly in the talks previously to me, that seizures, certainly acute seizures, increased metabolic demands on the brain, result in increased blood flow to areas that are affected by the seizure. In TBI, this alteration of blood flow can occur in a time frame when blood flow is low compared to normal levels based on some earlier to the injuries, and blood flow can also be altered later after the injury. So I think it's an extremely dangerous thing to have an injured brain start having seizures for any prolonged period of time, and I think it's therefore never desirable to have seizures after TBI. I just think that makes common sense. The question for this this discussion is whether anti-seizure medications are effective at improving outcomes, and that's not nearly as simple as the overall question of if you had a head injury, would you want to have a seizure or not have a seizure? So again, making this against case for the antiepileptic medications, the first proposition I would point out is that the medications we're talking about do not prevent post-traumatic seizures at all and do not improve outcome. This has been studied in several different forums. In 1990, this is the study that I mentioned earlier, New England Journal of Medicine, Nancy Temkin is the first author looking at post-traumatic seizures using phenytoin. The control group was placebo, and the phenytoin group is listed there. Again, you can see the Glasgow Coma Scale. It was not all severe injuries. There was about 60% and 67% GCS less than 10, so there was a fair number of mild and moderate injuries. There's any number of different mechanisms involved, and the seizures within 24 hours were identical between the groups. The points that my predecessor didn't make quite as strong is that the phenytoin itself caused enough drug reactions to cause people to not take it very long. So those are 200 patients in the phenytoin arm to start out the study. By the time they got to 2-year follow-up, which is what they measured, it was down to 58 patients. And the same with placebo, as people were down to from 196 down to 65 patients. So there was multiple reasons why people stopped taking their medications, whether it was the non-compliance or adverse drug effects. But there's obviously a cost that would be borne by someone taking probably any antiepileptic, particularly fosphenytoin or phenytoin at this point. Looking at the results, as was stated earlier, the placebo group had more seizures early, as indicated by this Kaplan-Meier curve, but conversely, the phenytoin group had more seizures later, and later was defined here as after 7 days. So I think this paper sort of formed the field of folks who are saying, let's do it for a week and see what happens. This sort of gave evidence to that opinion and credence to that opinion. Oops. But mortality rates, importantly, were absolutely identical between groups. So this is not a mortality effect. This study did not measure functional outcomes, neuropsychological outcomes, which are now contemporary parts of neurotrauma care. But this was a study done 25 years ago, so I had to give them some leeway, I think. The same group followed the study up with a more complicated study, assuming that phenytoin for a week was the standard of care. They then gave valproic acid for a month or valproic acid for 6 months as the 3 different groups. There was no placebo in this group at all. This study was published in 1999, I believe. Again, about 400 patients eligible, 120 patients about per group in the 3 different groups, and had a better compliance with taking their medications. You can see here on the towards the bottom of this table, about of 120 patients who started valproic acid at 1 month, 90 completed at 2 years. About the same percentage of this did at 6 months, and fosphenytoin for a week was obviously very highly compliant. Interesting enough, in this study, looking at the Kaplan-Meier estimate for the late seizure rates of patients assigned to the 3 treatment groups, if you got phenytoin for a week, you had the lowest chance of having post-traumatic epilepsy. And it's not even that close statistically from the higher group, for the 6-month group. And looking at the mortality rates, phenytoin for a week had a trend towards a better effect on mortality, although the P was 0.07. So it's not specifically demonstrating that it's actually beneficial to have less antiepileptic medications, but there certainly is a trend that makes you worried to give medications for longer periods of time. The second proposition I would make is that antiepileptic drugs may make things worse, not better. And clinically, this certainly can be seen by the medications can mask clinical exam in some cases, especially if you're using not levetiracetam necessarily. Fosphenytoin might have some effects on mental status, but clearly if you're using phenobarbital, which is a drug folks do tend to use in kids sometimes, you can have definitely effects on the mental status exam. The Dickman study, which is a follow-up from the first study I mentioned, looking at the neurobehavioral effects, demonstrated that these had idiosyncratic reactions happen frequently in a phenytoin group. And at 1 month, the phenytoin group did slightly worse than placebo in neuropsychological outcome. At 12 months, there were no significant effects observed. And at 24 months, there was more improvement in patients who stop phenytoin. So I think there is a, as our moderator mentioned in his first slides, need to sort of make our opinions sort of put them to the side a little bit. There is relatively compelling evidence that anti-epileptic medications on a long-term basis don't do anything good for patients. And one last proposition I'd like to make, again, pitching for pediatrics since I'm a pediatric person. The AED usage is widely variable across clinical centers. We're doing a center where Dr. Gupta's group is helping us with this study in pediatric head injury patients. We have this paper that we just put into the journal, looking at what medications do. This is across 41 clinical centers across the U.S., Australia, South Africa, and other countries, and found that only about 60% of sites even prophylactic do anything at all. When they do that, they have this wide variety of whether they use phenytoin or levetiracetam. And then in treating first-time seizures, the treatment people choose are widely variable between people using lorazepam, midazolam, levetiracetam, and phenytoin as their agents. So there are, and most people do not use pathways to study this at all, and these are in highly academic pediatric centers. So I do think there is a wide variability across centers as to what to actually do with this question, and I do have reservations about putting someone on long-term anti-epileptics from my point of view. But so to make the best case I can for this question, I think that there are no studies that demonstrate a significant benefit specifically for the seizures. I think there are studies that suggest that long-term use may be harmful across all patients. Maybe selecting which patients who need it the most will be better off. And there is absolutely no consensus on which agents should be used. So I think there are very, very much open questions on this topic in the TBI field. Thank you very much.
So maybe Dr. Manas can also come onto the stage.
Dr. Barnes, would you like to have a few points for the rebuttal of what he has said?
He concluded and he agreed with me. He said that long term is not useful, but short term is useful. So yeah, he said long term, and I agree. It means long term. I did not recommend for long term.
But short term for him is 7 days.
For 1 week, yeah. I also told 1 week on this, and the recommendation is 1 week. And if somebody doesn't use for 1 week, he'll be facing medical legal problems because it has been given as recommendations.
Now, can I ask a question to both of you? More for the sake of residents and students sitting here. Let us say you have a patient who is GCS 8 and you have a patient who is GCS 15. So between these two patients, would you like to use an anticonvulsant for 1 week, or would you like to give a more prolonged anticonvulsant usage for the patient who is in a more severe GCS?
No, for them, only whatever maybe the GCS is 7 days.
So even, would you like to change your prophylactic? Let us say patient is GCS 8.
So
would you
I think most of all the papers I discussed were for mostly severe patients, with GCS less than or equal to 8 in the current system that's in place. In my clinical practice, if that's what you're asking, aside from this debate, for the patients with GCS less than or equal to 8, I try to prophylax all of them. My neurosurgeons don't always allow me to because they want to not do it for everybody, so they don't always allow me to. It certainly, I think the mechanism of injury is important. The CT scan findings are important. If there's blood in the head, if there's other findings that seem to make it more likely that patient might have seizures. In pediatric population, a unique population which is different than most patients you probably see is there's a relatively high incidence of abusive trauma in our patients. Abusive head trauma in our patients have about an 85% chance of having seizures in the first week, so we give all them medications right away. But I think it does vary. It's not, to me, it's not an open-ended question at all. It's very much debated in my hospital every single day.
So even if the patient has got contusion or subdural, you would just give a prophylaxis for 1 week?
It's my practice to give for at least a week because they're out of my ICU by then.
That is
So
what is the recommendation. For early seizure, you only give 7 days. There is no rationale to give
So,
more than that.
so my question again is, in this group of patients, because they have to be supported in ICU or in a HDU, So if they have some metabolic problems or they are not conscious, how do we not rule out any provoked seizures, or how do we not rule out some non-convulsive seizures which may be happening and may not be helping them to recover completely? So
Means that is why the recommendation is 1 week, and people have done EEG, what presented the paper. 20% of them had.
Telling all the audience that every patient in the ICU should have EEG?
No, I'm
No,
not
but
telling. I
question
said
is
the
that-
studies
no,
has
he-
shown
his-
that
his
non-convulsive.
question is like that. You concluded that it has to only cover the early period, and up to 1 year, whatever anti-epileptic use, the sphincter and levatration has a higher incidence than those who did not receive it. That means you are telling the audience, use of anti-epileptics is harmful and the incidence is higher, right?
Yes.
Okay, so that you are telling whatever may be the situation, no anti-epileptic drug will be given beyond 7 days.
Right.
It's correct. Let everybody understood, no anti-epileptic drug will be given after the 7 days.
Yes.
Now the question is that he's telling, you are doing EEG and EEG shows lot of spike and waves. We will stop on 7 days?
Then the role it doesn't become prophylactic. It has to be therapeutic because you're seeing spikes, so it becomes a seizure,
No,
post-traumatic
no seizure. No,
It's a
because
non-convulsive status
non-convulsive
is
because,
EEG diagnosis.
because he is on a ventilator. He may be in the muscle relaxant. He could have a convulsive. It could have a
Yeah.
convulsive.
Yeah, but a non-convulsive
No,
status
no.
is a EEG diagnosis.
Non-convulsive is when a person is looking all right, conscious, yet the EEG show up abnormality. Here he is taking a severe head injury on ventilator for 15 days. On first 15 days, every day he has got a problem.
okay, so one question from Dr. Sridhar.
Very, very basic question. Like what Sarachandra asked, patient comes to you with a concussion, mild head injury, minor head injury. Will you give prophylactic anticonvulsant? Yes or no?
I don't know anyone who does that.
No.
No.
Right. When will you give the anticonvulsant prophylactic?
To minor head injury. To minor head injury.
No. They've said minor head injury, no.
Yeah, in severe injuries and moderate head injuries, you have to give.
So how do you define a moderate head injury?
International classification of
No. Please let us come back to basics. How do you define a moderate head injury? Is it by the CT scan finding or is it by GCS?
GCS.
By GCS. So you can a GCS which is low, that will define whether you give the prophylactic anticonvulsant or not.
Right.
Okay.
So for us, I try as best I can convince my colleagues to give anti-seizure prophylaxis for every child GCS less than or equal to 8. If a child is a GCS of 11, 12, or 13, but had a seizure in the field, I'm just saying that a lot of times we get reports of the child was hit by a car, had a seizure in the field, comes in and is waking up. That child I'll want to start anti-seizure medications on as well. But those are sort of the main groups that I would start these
No,
on.
I will ask one question. Which minor head injury will give suppose I am giving a situation. Glasgow coma scale 15, cerebral contusion on CT scan. Glasgow coma scale 15, he has a foreign body, pellet in the bone. We taught our undergraduate, if the post-concussion period is longer than, or post-traumatic amnesia more than 24 hours, if there is a foreign body in the brain despite of his Glasgow coma scale 15, a person who has severe headache in post-concussion period, a person who has been confused for longer time, or CT scan shows intracerebral contusion or subdural hematoma. But his Glasgow coma scale 15, will you give them for 7 days or not? The
Yeah.
question is that what are the high risk factor in a so-called minor head injury, right? So-called, this is common
Yeah.
what we practice. Dr.
Yeah,
Karthik
if-
practice the same way.
Yeah, means patient
Have a
having
longer
GCS 8 or
post-traumatic-
higher risk factors. That is what is the recommendation.
Yes. Those are, you should tell
Like
that.
if you have a penetrating injury, the risk is 50%. But then again, it is recommended for 1 week only. It's not recommended that you continue it for
So
more than
you are
1 week.
telling minor head injury will also give when there is a high risk factors.
Yes.
And those high risk factor 5, 6 you have to tell them. Because there are people, those who don't know what are high risk factor. If there is the dural penetration, if there is a foreign body, if there is a depressed fracture, if the post traumatic amnesia is more than 24 hours, is not correct? I don't know he agree or not.
But these will not be classified as
No,
mild.
let him say. Na? I am only telling what we practice for last 30 years.
But these are mild complex
I
TBI.
think the difference is that I think mild TBI for me means negative CT scan.
That's right.
So if you have a mild GCS score but have a CT scan that's positive, a lot of people use this ridiculous phrase of complicated mild that people use. So I can't list all the different scenarios you had, but I tend to give anti-seizure medications to patients who had a seizure before, who have some blood in their head that's not in the right spaces, and GCS is lower than 8. That's my basic criteria.
So I just want to ask one more question to clarify. What are the situations where the GCS is less than 8 and CT scan is positive? Would you like to give, in absence of any seizures, would you like to give AEDs for more than 1 week? No seizers, GCS less than 8, CT scan positive. What are the situations where you would like to give?
So in that situation, I give the anti-epileptic medications as long as they're in the ICU with me, because a seizure in the ICU will keep you in the ICU for another couple of days because people get nervous. So I don't have any data that says if you have anti-medications for 10, 11 days, it's different than 7 days. So in that situation, I'll keep the anti-epileptic medication on board until they go to the floor. They'll undoubtedly get stopped on the floor, and if the kid seizes again, they'll come back to us.
No, but that means it is not a rule of 7 days. You will break the rule for certain people.
Well, if a patient has multiple devices in their head and is in barbiturate coma and things like that because of their severe TBI,
there will be a situation.
then I leave them on for that reason. But
So there will be situation.
I wasn't trying to deceive anybody.
So there will be a subgroup of patient when the anti-epileptic is continuing beyond 7 days, right?
No, means there are papers which are the people who underwent craniectomy, means decompressive craniotomy, they had a higher seizure than the patient who were conservatively treated with CT positive. But then, though anticonvulsion was given, again it was not statistically significant.
Okay.
So the situation you are telling, you are right if you give, you are right if you don't give also.
Right.
there's one more question.
Okay.
Yeah.
One more, the last question.
Yeah,
Please make it easy.
it's a
I'm
very
sorry.
controversial topic. I think this is very interesting. We never do anti-seizure prophylaxis. But I have a question. Yeah, if you decide to start the anti-seizure prophylaxis, with which criteria you interrupt the treatment? Yes, stop. Yes, because it's a big problem. If you start with the treatment, how long do you do the treatment, and with which criteria do you stop it?
I think the question is a very good question. I think it depends on your goals. I think if you're trying to stop seizures in the acute period, you wait till the brain injury is recovered enough that you feel like you're not going to have trouble with. And if your goal is to stop post-traumatic epilepsy, I think your data does not support the fact that you're actually going to do that.
No, I think I can.
Depends on your
thing
goal.
I want to ask. I don't know how many of you read "If My Son Has Head Injury" written by Brian Jennett in Lancet 1975. The question debate was that time minor head injury to be admitted or not. He says, I say everybody minor head injury not to be admitted, but if my son has a head injury, I'll do it. So same thing, we talk about IC monitoring severe head injury, but ask what will do for your son? What happens your son has a clot in the brain and would you stop the anti-epileptic on 7 days? It's very nice to advise the audience and the public, but what will you do for your own relative, your wife, your son, your daughter-in-law? The question is that answer is not easy when it comes to answer. That's the reason Brian Jennett told in 1975, what do I do for my own son's head injury? I will admit minor head injury. Controversial, admit, not admit. Now the controversy for his son is different. So a individual patient would be very difficult to tell, right? You cannot.
Yeah, the drawback is the side effect of the anticonvulsants. Over decades we are having better anticonvulsants. Like levetiracetam has a lesser side effect, so we are slowly accepting it. Maybe in future you have a still better one where you can extend the indications of anticonvulsant and the criteria also will change.
So thank you very much.
Give everybody
Very big hand. So with the permission of the chair, I'll just want a show of hands. If the patient is good GCS, CT negative, how many of you would still give prophylactic anticonvulsants in your practice? More than 8 GCS.
No, not more than 8. 15 or what?
Yeah, 15 GCS, CT negative. How many of you would give prophylactic anticonvulsants? Okay. Next is GCS less than 8, CT positive. How many of you would give more than 1 week?
A lot of people.
A lot of.
Thank you.
Okay. Thank you very much.
We have got the answer. Again,
We're
I am
going to
telling-
move on to the next CME, which will be about brain protection and anesthetic challenges in traumatic brain injury. I invite the chairpersons for this session, Dr. H.H. Dash, who's a neuroanesthetist at Fortis, Delhi, Dr. R.S. Chauhan, additional professor neuroanesthesia at the All India Institute of Medical Sciences, and Arthur, who's come all the way for us from Brazil. He's a pediatric neurosurgeon.
Good afternoon, everybody. Without wasting any time, let's start the session on perioperative management of patients with head injury. Long press. Long press. Okay. Leave it. And to start the session, Professor Michael Bell from USA will be speaking on prophylaxis of DVT in patients with head injury. Michael.
Thank you very much. You guys are exhausting my knowledge of TBI. I'm sorry that I'm dominating the conversation the last little while. I do know more about ICP monitoring than I do about antiepileptics, and I know least about deep vein thromboses, so I'll keep this brief and try to be to the point. So my hope for this talk is to briefly discuss the prevalence of deep vein thromboses after TBI and discuss the treatment and non-treatment of these incidences. And most of this talk will be focused on some children some children's studies to sort of try to give you a different flavor of the condition, but I think we could give a broad-ranging talk on how to decide when to use deep vein prophylaxis against DVTs. So DVTs and TBI are closely linked. It's one of the most common complications of critical illnesses. In a series of about 13,000 pediatric admissions in over 40 centers in the US, the deep vein thromboses were located in these different locations: lower extremities, upper extremities, the vena cava, and then unspecified based on poor documentation of the medical records. There's some well-known risk factors of DVTs that I think we all learned from medical school. Hypercoagulable conditions, which can be genetic or could be acquired based on medications. Lack of movement of limbs, being non-mobile, either from being a head injured patient or being on planes for too long a period of time. Pregnancy, cancer, obesity, smoking, these are all factors that can affect the risk of having DVTs. And in our case, really trauma and central venous catheterization are large risk factors for the patients we're talking about. This is an ultrasound of a DVT inside of a vein, which is virtually occlusive. And you can see here how the blood will not be able to flow past this obstruction. The cartoon on the bottom of the slide tries to depict the different ways or different stages of DVTs occurring in this. In this cartoon up here is a normal blood flow through the vein. You can see the valves in the vein here, and the blood is just circulating at will, and obviously this is at a normal state. You get an early development of a thrombosis either from a catheter being poked into the vein, or the vein being damaged after trauma, or activation of different kind of platelet cells and different kind of adhesion molecules, which can cause platelets to start adhering to different vessel walls. Once this happens, you can have continued development of thrombosis, which then becomes mature from the activation of the coagulation cascade and development of a fibrin plate. And then eventually, the worst case scenario is when part of this becomes an embolus and can be thrown into the circulation and can go to the lungs and have a pulmonary embolism, which is obviously the thing we're trying to avoid. Prevention of and treatment of DVTs is actually kind of hand in glove a little bit. The first way to prevent DVTs from occurring is to eliminate the risk factors. So early movement of extremities, if it's possible and safe, obviously will be helpful. Weight loss, cessation of smoking, these kind of things, which are things we can't change in the head injury patients, obviously. Compression devices are very effective and should, I think, be used very liberally. And then the question is low-dose anticoagulation or not. To treat DVTs, you use either treatment levels anticoagulation, intravascular devices, filters, or thrombectomies. Now, the problem with those strategies is this patient we're going to talk about for about 2 minutes here. This is a patient of ours who's a 14-year-old girl who was hit by a car. You can see here she has a contusion in her frontal lobe and actually into her temporal lobe here. And the question of, and she developed a DVT on day 4 of hospitalization. So the question that gets percolating around my hospital is, do we start heparin now or not? Should we bother with the treating the DVT or not, based on this head injury, which was severe and could get worse with any bleeding. So as we've talked about a lot today, it's the risks and benefits that you need to sort of, consider the risk of the DVT, which is someone going to develop a pulmonary embolism? Are you going to get damage to the limb for some reason from the thrombus being there? Versus the risk of the DVT treatment, which could be hemorrhagic concerns based both in the head and systemically, and then device complications as well. So this study done from the state of Pennsylvania tried to answer the question is, are pulmonary embolisms more common in head injury patients or not? And you can see here that pulmonary embolism rate increased with age at a relatively consistent rate. So the older patients are at more risk for having pulmonary embolisms based on this study that included the entire state of Pennsylvania. Again, this is I think a 100,000 patient database, so they have lots of patients that they can split up. And closed head injury, severe GCS less than or equal to 8, was a factor of getting pulmonary embolism, as was spinal injuries, femur fractures, and pelvic fractures. So again, so TBI does seem to be a risk factor for development of pulmonary embolism, although it wasn't greater than these other causes. If you look at all patients with head injuries, about 48,000 patients who had this, the incidence was about the same between the GCSs of greater than 8 and the entire population, but there was an increased risk of having pulmonary embolism for patients who had the severe GCS based on the category system we talked about all day today. So it does appear there is an increased risk of pulmonary embolism. Again, this large database across the entire state of Pennsylvania. Other factors that are associated with increased risk, again, sex, age, injuries related score, ICU days, and these other lists of factors here. So I think as you look at your head injury patient, you need to sort of consider, are they at risk for having pulmonary embolism or not? And in pediatrics, it's a vanishingly small patient population that is actually at risk. So we do have I think a skewed view. As for thromboembolisms after trauma, another paper from the Traumatic Coma Data Bank, 1,600 patients who had thromboembolisms. Age greater than 40 was a factor, as was pelvic fractures and head injuries with an AIS greater than or equal to 3, which generally comports to being a severe injury, although it's a little bit fuzzier. And then having a major surgical procedure is another risk factor in shock upon admission. Looking for independent risk factors which can get past this univariate analysis, age, extremity fracture, head injury also did come out as having an independent risk for thromboembolism. They surveyed trauma centers as well to see what their prophylaxis should be and what they used. So if there was no contraindication to heparin, about half the groups used low molecular weight heparin as a first line and compressions as a second line. This was also a little bit increased when you compare both of them together. If there was a contraindication in this group, no one used any heparin at all. Most use compression stockings or foot pumps, as well as some placing vascular filters in the vena cava. This is a schematic that came from the same paper, and it was a better schematic than I had for my personal practice, so I decided to put it in the talk and allow you to take a look at it. So in this group, they looked at patients with high risk factors for developing a venous thromboembolism, and if they had a contraindication to heparin, and they said yes, they just did compression. If there was no, they used low molecular heparin. This is their schematic. If they had a very high risk factor for venous thromboembolism based on these factors plus these four, they did use low molecular heparin if there was no contraindication, and they put a filter in and used mechanical devices for those cases. So what do the guidelines say? And this is the TBI guidelines that are coming out shortly for adults and for children. For children, there's no even topic for this. There's not even a mention of venous thromboembolism in children with severe TBI. The adult guidelines is listed here. You can see this long-winded discussion where it's sort of getting at is that there's so much uncertainty about the differences in the physiology and the pathologies to warrant a caution in who should get any prophylaxis. And so I think the topic is still very murky in the TBI field. From my point of view, what do we do? And our trauma team screens for DVTs very, very frequently, which drives me a little bit crazy because they find all these small DVTs that are associated with central lines that I think have no pathological relevance, but it gets everyone excited. They want to start heparin. For most patients with severe TBI, we just do compression therapies on the extremities, and that's really all we do. For symptomatic DVTs that are not related to catheters, we consider a vena cava filter. We put in about 3 or 4 of them this year, and especially if the patient has ICP monitors and has a hemorrhage at all in the brain. For symptomatic DVTs that are related to catheters, we generally change the site of the catheter and try not to place filters in those patients because we think the risk is pretty small. But there is a growing drumbeat in our hospital and other places to start heparin. But our neurosurgeons will generally not allow patients to get heparin for the first several weeks after a monitor is placed in severe patients. I'm really happy to sort of hear your practices, and I did intentionally leave this talk a little bit short so we could get some feedback because I'm interested to sort of hear how your places are solving this. So I'm just going to stop now and say thank you, and please approach the microphone and tell us your practices. Thank you very much.
Thank you, Dr. Michael, nicely highlighting the importance of DVT and its prevention. I think we use mechanical compression and low molecular heparin, but as usual, as you told, in pediatric patients, hardly we have seen. I think what is your? Keep it placed. Yes.
There you go, you're fine.
Okay. Yeah, thank you. It depends the age. By young children, we whenever use prophylaxis, the thrombosis prophylaxis, but by old children we use very often. Yeah, and I think this is very important, especially for children that have a long stay in the UCI.
Yeah, I think we have had patients we had a patient I remember pretty vividly who had a broken pelvis as well as a head injury, and she had a pulmonary embolism and was very ill with it. So I think the pathophysiology behind it is what matters more than the age of the patient. I think these catheter-related things are just things we find based on ultrasound imaging, and I think it's less relevant than the actual disease itself. Yes, sir. Got you behind the screen this time.
Yeah.
Well, thank you for your overview of the principles and allowing us to share practices, because I think one of the factors that play a role in when to start the DVT prophylaxis is the stability of the intracranial injury. So if there is a contusion in day 1 that is stable till day 3, then you can start the low molecular weight, no, sorry, not necessarily low molecular weight, it's the unfractionated heparin, for the notion that if it expands, you can reverse it by a calculated dose of protamine. That's, but I agree that the IVC filter in patients with multiple contusions or dissecting contusions, then there is no role except for the IVC filter in a high-risk patient.
Well, thanks for the comment. I do think actually we had a discussion in our place as well about the unfractionated heparin, and we have actually found a dose of protamine that does reverse even low molecular weight heparin. So we have been able to do that. It takes a little bit longer. It takes about 2 hours to reverse instead of instantaneously, but I do think there is possibility. Thank you very much.
Thank you.
We invite now Professor Dash that speak about anesthetic challenge in head injury.
Thank you, Dr. Deepak, for inviting me to speak on anesthetic challenges. Oh, head injury. Sorry. I have brought greetings from Fortis Hospital, Gurgaon, and thanks to Dr. Deepak for inviting me to speak on challenges during anesthetic management. The challenges, once you are called to the emergency department or once you are called by your colleagues to the intensive care to manage a head injury patient, the challenges starts from there. And to overcome the challenges, you must have some basic knowledge about the pathophysiology of head injury. As you know, the first 10 minutes is very crucial phase in the management of head injury, because during that time, because of the sympathetic surge and apnea, everything goes topsy-turvy. So you'll have to be very careful about this. And the other thing is, one has to remember, soon after the head injury or the primary injury, it is the secondary injury which is the most important cause and where the anesthesiologist play a dominant role in preventing morbidity and mortality. And the causes of secondary head injury, of course, the number one is the hypotension and hypoxemia and intracranial hypertension. And the other contributing factors may be hyperglycemia, hypoglycemia, and hyperthermia. And all these things have to be looked into and taken care of if you want to provide adequate perioperative management of this patient. This is a study carried out by Clifton and his colleagues about the mild hypothermia and head injury. And while analyzing why this study became a negative one, and they found out that it is the fluid balance. Of course, the GCS admission, age, mean blood pressure, and ICP all are predicting outcome following head injury. But lo and behold, they found whenever the patient remains dehydrated more than 600 ml, there also the mortality and morbidity was also very high. So previously, the neurosurgeons used to think if you keep the patient little dehydrated, the ICP will remain low and the patient will improve, but that is absolutely wrong. And the other thing is the hyperglycemia. Whenever the patient's blood sugar is more than 200 milligram per cent, the ICP increases, and that increases the mortality and morbidity. And whenever the patient comes with hyperglycemia, try to manage the blood sugar in and around 160 to 180. Nowadays, the tight control is not advocated anymore because of the episodes of hypoglycemia. And what are the preoperative assessment and care? And the goal is always how to prevent the secondary head injury. And the best way to prevent secondary head injury, assess your patient and secure the airway, institute breathing, take care of the hemodynamics or maintain the blood pressure, and then of course brain protective strategies you will have to take, and assessment of the associated head injury. This is a case report published from our, of course, when I was in All India Institute. 3 pediatric patients in this case report we have highlighted. One patient had ST depression. This was a 6-month-old baby. Another 4-year-old baby had bradycardia, and another 9 or 10-year-old guy had cardiac arrest in the intensive care. And you can see the ECG, and once you'll see the ECG, you'll run for the cardiologist help. But we never ran for the cardiologist help. And this occurs because of the stunned myocardium due to intense catecholamine release following intracranial hypertension and in the head injured patients. And all these patients were resuscitated, taken into the operation theater, operated, electively ventilated for 2-3 days, and they were discharged home. So never ever get worried if you come across such cardiovascular problems in your head injury patient. Coming over to the initial management, as I have told you, securing the airway, because you'll have to take care of the cervical spine, because around 10 to 15% of the patient may have cervical spine fracture. So manual inline traction with orotracheal intubation is the ideal way to secure the airway. And if the patient is like bleeding like this, you can prevent the bleeding by putting this catheter and distending the balloon, and securing this airway at times gets difficult. And of course nowadays intubating LMA is there. One can resort to this intubating LMA, and if you fail, then cricothyroidectomy can be done. Coming over to the monitoring methods, both cardiorespiratory monitoring has to be carried out, and you can see the respiratory parameters, the tidal volume, compliance, and the rate, and of course the intracranial pressure, and of course temperature can be monitored. Fluid resuscitation is of paramount importance during early management of head injury, because and the normal saline is recommended. Glucose solutions are absolutely no-no, because it may aggravate the ischemia and it may increase the brain edema. And if the blood pressure is not able to be maintained, then one can go for the colloids, and lastly vasopressors. And if there is a good amount of blood loss, then one can resort to administration of blood. And once your patient is hemodynamically stable, then you assess for the other injury, chest, pelvis, long bones, and abdominal, because it can conceal big hematomas. So you must assess. And coming over to the principles of the anesthetic management, first and foremost, how to optimize the cerebral perfusion so that the intracranial pressure remain well maintained, and avoid cerebral ischemia, and maintain the intracranial pressure within normal level, and try to provide a better and conducive atmosphere to the surgeon by taking care of the ICP. These intravenous anesthetic agents, all anesthetic agents can be used, and synthetic opioids, they all decrease the cerebral blood flow, decrease the CMRO to maintain autoregulation and CO2 reactivity, and all are brain protectants, and of course thiopentone and propofol are being used, and etoposide has got cardiovascular stability. Of course ketamine we don't use, because ketamine may increase, but again there is reemergence of ketamine. And all inhalational anesthetic agent of course increase the cerebral blood flow, but they decrease the CMRO2, they try to maintain the autoregulation and CO2 reactivity in and around normal. But nowadays sevoflurane and desflurane being used, and in some centers isoflurane is also used. This is a small study we carried out at All India Institute in order to replace suxamethonium, because suxamethonium one can use whenever you face difficulty in intubation, because within 30 to 45 seconds you get excellent intubating condition. And we had used rocuronium, 1 milligram rocuronium can provide also excellent intubating conditions in such situations. And there is no fasciculation and no minor increase in the intracranial pressure. And anesthesia can be well maintained with oxygen nitrous oxide. Of course, nowadays nitrous oxide has been deleted from the list, and oxygen air with isoflurane or sevoflurane and IPPV. And of course, for induction, thiopentone and propofol and muscle relaxant, non-depolarizing muscle relaxant can be used. And to maintain the blood pressure within normal level, and to keep the ICP within the normal range, one can use lignocaine 1.5 milligram 2 to 3 minutes prior to intubation. And this is another study we carried out at All India Institute when I was there, whether to find out which one is better, sevoflurane or the desflurane. This was around 50 patients we studied, and the brain conditions provided by these two agents were more or less comparable, and the ICP was also in and around normal range. And one can use both sevoflurane and desflurane. And of course, intraoperative problems one can face is the arrhythmia, intracranial hypertension, the brain may be bulging. So one can give, along with mannitol, one can small dose of Lasix, or you can use thiopentone or propofol. Hypotension and hypertension. Never ever allow your patients to develop peaks or valleys in the blood pressure, because that is very dangerous. And take care of the arrhythmia, and the core temperature has to be maintained in and around the normal range. Coagulation disorder have been mentioned, but it is very rarely encountered during surgery. Of course, the patients who are 9 to 5 Glasgow Coma scale, we always try to extubate, and during extubation one must avoid coughing and bucking on the endotracheal tube, for which one can use lidocaine, or small dose of fentanyl also is very effective in controlling this coughing. Elective ventilation always we carry out whenever the patients are less than Glasgow Coma scale and 8. General care in the postoperative period, seizure prophylaxis has already been dealt with, infection control, nutrition, physiotherapy, and DVT prophylaxis one must take care, and always we allow nutrition next day or even in the same day. I mean oral, not oral, through the Riles tube. Some of the patients may require prolonged ventilation if the Glasgow Coma scale less than 5, and early tracheostomy is very good, and some may need long-term ventilation, and of course pressure cycle ventilation may at times be useful. Severe patients with extracranial injury, this data shows that the recovery pattern is more or less comparable if you operate the extracranial along with the intracranial region. And early fixation of the in moderate to severe head injury is there is no problem in early fixation. Thank you very much.
Thank you, Dr. Dash. In the most of severe TBI cases, the secondary lesions are the most important prognosis factor. And I think the big challenge is identifying the problem and the right time to intervene to prevent the secondary lesion. Questions?
All are anesthetized.